Okay, my name is Nabil Said, and I'm moderating this session on behalf of Giving Back to Pharmacy in Pakistan, which is an organization of volunteer pharmacists from around the globe working to share knowledge and best practices to improve pharmacy practice in Pakistan. A brief introduction of mine. I am a pharmacy graduate of Rifa International University, Islamabad, and currently working as Assistant Manager Pharmacy and Training and Development Coordinator at Creek General Hospital, Karachi. The main theme of today's session is fasting on pills, and we have two very honorable and experienced speakers with us. Before moving towards the introduction of our speaker, for e-certificates, link will be shared in the comment box, and don't forget to fill the feedback form shared in the comment section. Okay, our first speaker for the today's session is Dr. Munazza Quraishi, who is a clinical pharmacy specialist at Tabba Heart Institute. She has done her PharmD from Karachi University and MBA in Health and Hospital Management from Buckeye University. She started her career from Aga Khan University Hospital and served there for 8 years. At AKUH, she worked in critical care, surgical medicine, pediatric unit with clinical participation in critical care and neonatal rounds. She is now playing a role in establishing anticoagulation services in Tabba Heart Institute. Dr. Munazza Quraishi, over to you for the presentation.
Thank you so much, Nabil, for your introduction. Assalamu alaikum to all of you. As Nabil have introduced me, I am Munazza Quraishi. I'll be presenting here a talk on anticoagulation management while fasting. I do not have any disclosure to make. Sorry. Okay. So we are here just before start of Ramadan, and today our talk will be focused on how anticoagulation management will be done in the month of Ramadan. So our learning objectives will be detailed insight on commonly prescribed anticoagulants, discuss common lifestyle modifications that need to be done in the month of Ramadan, and understand few and yet important drug food interactions. So why anticoagulants? Why anticoagulants? It can be the basic question at rise to anyone. So anticoagulants, as we all know, are drugs that are used to prevent coagulation of blood, and thus it prolong the clotting time. And due to this feature, anticoagulants, the class of drug that has been associated with serious adverse drug reactions. There are many, I must say, there are countless case reports indicated that the use of oral anticoagulants in any setting may result in harm when are not used appropriately. That can eventually result in hospital admissions, or when a patient is admitted in the hospital, it can prolong its stay. So the anticoagulant has been classified as high alert medications according to Institute of Safe Medication Practice, that is ISMP, and it is because that they have potential to cause harm. There are many reports on bleeding risk of anticoagulants, and when they are used with other drugs that have interaction with them, they increase this risk. Also, there could be chances that the drug treatment can be duplicated, and there can be dosing errors. There could be accidental discontinuation of anticoagulants that could lead to serious consequences, and also when there are problems associated with the monitoring of anticoagulants. So basically, anticoagulants are considered as main treatment options for the patient with thromboembolic diseases. And as we know that the major adverse effect of anticoagulants the major adverse effect of anticoagulants is the risk of bleeding. So, according to a study that has been shared by ISTH, that indicates that the annual risk of major bleeding is relatively high when a patient is on anticoagulant. And when a comparison is made between DUAX and vitamin K antagonist recipients, it came out to be that vitamin K antagonist recipients, like warfarin recipient, have a major risk of bleeding as compared to DUAX. That's the study that has been shared in ISTH, International Society of Thrombosis and Hemostasis. So, coming to anticoagulants, there are two types of anticoagulants. One, basically, according to the route of administration, we can classify them as injectable anticoagulants. In injectable anticoagulants, we have low molecular weight heparins and fondaparinux. Both of the drugs that are used through parenteral route or injectable route are administered sub-Q. Enoxaparin is usually indicated in twice daily dosing and can be administered in Sahar and iftar times during Ramadan. So there is no harm in taking, there's no mismatch in taking enoxaparin during Ramadan. Following fondaparinux, that is also easy to manage because it's a once a day dosing, daily dosing, and it can be administered at iftar times. The major concern arises with oral anticoagulants. So orally, we can classify anticoagulants as a vitamin K antagonist. The example is warfarin, and direct oral anticoagulants, also known as novel oral anticoagulants. And the example include dabigatran, rivaroxaban, ipexaban, edoxaban. So, while comparing these two classes of oral anticoagulants, we have a safer bleeding profile as compared to vitamin K antagonist for DUAX. And similarly, there are no major drug-food interactions with DUAX. Also, there is no definite monitoring parameter for DUAX. One of the major difference between warfarin and specifically targeted anti-oral coagulants is that we need to have INR monitoring for warfarin, and it is not required for DUAX. Similarly, the agent does not require any modification in diets. DUAX does not require any modification in diet because it does not depend on vitamin K dependent factors. It directly inhibits factor 10A or thrombin. Dabigatran inhibits thrombins while the rest inhibit factor 10A. One of the most important consideration considering these two oral anticoagulants is the cost. The newer anticoagulants are relatively expensive as compared to warfarin, but they tend to have a safer profile as compared to warfarin. So as I've told you, there are no major drug interaction with DUAX, but one listed is with rivaroxaban. That is, grapefruit can increase the plasma concentration of rivaroxabans. Otherwise, there are no major drug-food interactions, and they can be taken. Ipexaban, edoxaban, dabigatran can be taken with or without food. They have no limitations to it. While it's recommended to take rivaroxaban with food. So coming to the point, why warfarin? As we know that warfarin is a neurotherapeutic drug index drug. It's 99% protein bound and it's metabolized in liver. So warfarin basically acts while inhibiting vitamin K dependent factors that are factors 7, 9, 10, and thrombin, that is factor 2. The half-life of these factors usually vary. So usually they have different half-lives. So warfarin needs time to produce its action. Usually around 60 hours time is needed by warfarin to produce its action. Warfarin is usually indicated in different indications like pulmonary embolism, arrhythmias, venous thrombosis, mechanical heart valves, that mechanical valve replacement, and transient ischemic stroke attack in patients. Also, patients who require anticoagulation and are renally compromised that are more likely to have to receive warfarin than any of the DOACs. Coming to the factors that affect warfarin dosing, so we can classify them as clinical and environmental factors and some of genetic factors. The percentage of genetic factors remain low, but there are some genes that may interrupt with warfarin dosing, like it's vitamin K, it's cytochrome P2C9 and cytochrome P4F2 and VKORC1, that is etopoxide reductase complex subunit 1. These genetic factors do affect warfarin dosing. Other than this, there are some clinical and environmental factors also that affect warfarin dosing, and they include they include age, body mass index, gender. They include interacting medications. They include with specifically in consideration with the month of Ramzan. They include nutritional status of the patient adherence to have anticoagulation daily, and the diet the patient has been taking in the month of Ramadan is of crucial importance while considering the dosing of warfarin. So here's some literature review for for anticoagulation. Unfortunately, I'm unable to find much literature on this. That also opens up an opportunity for me to have a study on this, like what are the effect of fasting on Muslims and what are the INR in during the month of Ramadan. Unfortunately, I am not able to find any data from Pakistan or from subcontinent. That's a study that has been published in ISTH by ISTH in Journal of Thrombosis and Hemostasis. The study is published in December 2013, and the study was conducted in Singapore. And so it includes a number of 32 participants. The finding of this study on the effect of Ramadan fasting that was conducted on 32 Muslim patients taking warfarin, whose weekly INR was monitored, and these are the patients that were previously have stable INRs, and the study was conducted with 3 equal months. Like first is the observational month, that is the pre-Ramadan period. Then an interventional month, that is Ramadan period, and then they follow up, that is post Ramadan. So The study showed that there is a significant increase in mean INR by 0.23 E ratio, and during from there's an increase in INR from pre-diabetic pre-Ramadan phase. Pre-Ramadan phase, there's an increase in INR, and also when there have been followed after after Ramadan, the INR of these patients decreased by 0.28. So the study suggested that Ramadan and fasting do affect the do affect patients' INR, and it's a consideration that fasting, according to that study, they have attributed some facts that there is sleep deprivation in Ramadan. There are long dehydrated phase of fasting, and there is a change in vitamin K containing diet. So that these could be the reasons that solely attributes towards raise in INR in the month of Ramadan. Also, there's another study uh, that is from Journal of Saudi Heart Association, and they specifically focus with the prostatic heart valve patient. Those patients were taking warfarin for anticoagulation, and in this study, around 18 patients were enrolled in this study, and they were also followed for a period of pre-Ramadan, Ramadan, and post-Ramadan. And in this, the blood samples was collected. This study usually suggests that there is no difference between INR and they have found that there is no significant difference in pre-Ramadan phase and post in Ramadan and after post-Ramadan. There is no significant difference in patient therapeutic monitoring uh, of INRs. So they have not listed that what are the eating trends, what are the dietary intake of people there, but as far as as far as we know about them, they usually prefer to have big foods. So they have maybe they have maintained a balanced lifestyle in the month of Ramadan. Coming to what lifestyle adaptations can we made in a month of Ramadan, as we all are aware that the subcontinent culture is more prone towards uh, towards a social life enhancement in the month of Ramadan. We have social gatherings in month of Ramadan, and we usually focus on our meals at iftar that are high, that are rich, actually rich, and we usually prefer to have fried items. We usually prefer to have some a mixed variety of things present on our iftar tables. Also, when we fast for around 14 to 15 hours, we have left for about 10 hours window that in which we some of us have our iftar, then sahar, and some might choose to have their dinners also. So there is a 10-hour window then in which we are having all sort of meals. So there is a change in the pattern than normal days. So it does affect the INR. Similarly, the dietary changes, as I have spoke early, that we are more indulged towards fried items. We are more indulged towards having fruit salads and beverages on our iftar tables. So they do cause a shift in INR. They do cause a shift in INR. So while what is recommended? It's recommended to have warfarin dosing at 5 p.m. in normal days that we usually do with our patients. We recommend them to have warfarin at 5 p.m. in normal days, and with exception of 1 hour, it could be lead to 6 or 7 p.m. But in Ramzan, what we prefer is to uh, uh, have a to have warfarin 1 hour after after having moderate iftar. Like, do not eat full and have a moderate iftar, then have warfarin, and then you can later have something if you want. So there's not a problem with DWACs. DWACs are usually prescribed in once a day dosing or twice daily dosing, and that easily can be covered in Sahari and iftar times. So there are some potential drug food interactions. As we know that black tea could be one of them, ginger garlic could be one of them that you majorly use in this subcontinent, in this part of the world, and papayas that we use in summer seasons, and that could lead to increase in INR. So there's a myth that by using ginger garlic, you can eliminate heart diseases. So majority of our population that I face in my anticoagulation clinics are usually asking me, so can we take garlic with it? We do not need to have a warfarin further, and it will eventually thin act as an anticoagulant. So the risk of bleeding potentially increases in this sort of patients. So you need to educate them. You need to educate them that it's not the right way of dealing with your disease. You need to have a balanced diet, and with that you need to take your medications as well. So do not it's not totally prohibited that you cannot have a papayas, but it's like you can have it in 15 days or in a week, a small quantity of it, so you can maintain a balanced lifestyle. It's just about maintaining a balance between in your diet. It's not more than that. So there are some possible drugs that can decrease warfarin effect as well. And in this we have green tea, and as we all know, vitamin K containing foods, the food that are rich in vitamin K, and his list. So what are the recommendations? Uh, there are there is a Kanachi, there is a calculator that per 100 gram of serving, if it's contain 80 micrograms of vitamin K, it's considered as a high content of vitamin K. 30 to 80 gram is considered as a low content of vitamin K, and below 30 microgram is considered as low. So sorry if I have read it out wrongly. It greater than 80 is high, 30 to 80 is medium, and less than 30 is low. So we need to focus, we need to tell our patients to have a concentration on low content of vitamin K. Low content of vitamin K is advisable to our patients. They can have it. They can take there are different categories, and you can as you can see, in fruits you can have apple, banana, berries, grapes. They have low content of vitamin K. But definitely, while taking all these things, you should have to take them in moderate quantities. You do not have to rush after it. You do not have to have a big serving of these things, because it will affect your warfarin therapy. Similarly, the green leafy vegetables that majorly have high content of vitamin K, that are indicated to be avoided while while having warfarin therapy. So in this we have spinach, broccoli, cabbage, and it have So these turnip greens also, then cucumber peels. You can have cucumber that, but without peel. So these are something that need to be avoided, or if taken, then it should be restricted to 1/4 of your plate, 1/4 quarter of the plate, and it should not be exceeded once in a week. So if you are taking any of these green leafy vegetables in 1 week, so do not repeat any other in the same week. That's the key, because it does, the literature does say that you can have a quarter of these quarter cups of these green leafy vegetables per day, but practically when we see our patients and they are having these um, green leafy vegetables, it affect their INRs and the INR decreases. So for to maintain a therapeutic window and to maintain a balance, you need to educate your patients that taking the green leafy vegetables once a week and do not repeat any other in the same week. So there is no harm in taking beef, chicken, tuna fish, turkey. There's all good, but beef liver, chicken liver is a high content vitamin K food, so it must be avoided. With warfarin, there comes the consideration of monitoring. So whenever warfarin is indicated to any patient, you have to counsel them. You have to regularly check your INRs. You have to get your INR done weekly if your INR is not stable. And once it's stable, then you are indicated to have your INR once in a month. But as our literature, as there's limited literature available, and also there's no literature in our setting. Also, I have skipped one thing here, that we used to have um, chickpeas in our iftars, and that also contain medium content of vitamin K. So do not take chickpeas regularly in your iftars. Usually it's a practice in our setting in our country, that we used to have chickpea salads in our stars, but it contains a medium content of vitamin K, and having daily basis having chickpea can lead to a decrease in iron. So it's advisable to have twice weekly, but not more than that. Coming to monitoring, so I for the conditions like arrhythmias, pulmonary embolism, therapeutic INR ranges between 2 to 3, and for that is only for mechanical wells, that INR ranges from 2.5 to 3.5. So a subtherapeutic INR is anything that is less than 2, and a supratherapeutic INR, that's anything that's greater than 3.5. So as there is limited studies and we do not have much literature to support any kind of to suggest any kind of recommendations, what we can do is to counsel our patient to get INR done. If a patient have a stable pre-Ramadan INRs, it's indicated to have INR once in 15 days for stable patients. And for patients who are just starting on warfarin therapy or who are fluctuating INRs, then it's recommended to have INR on weekly basis. So we'll calculate their weekly dose and we'll then adjust warfarin dose accordingly on weekly INRs. That is according to the nomograms available. So you can have nomograms from Lexicom or anywhere. So according to that, you can adjust your warfarin, and there could not be a point when the patient is in risk, because you are weekly monitoring the patient, so you can adjust the doses um, and adjust lifestyle also. One of a practicing experience that I would like to share, that in our part of country there is a mixed I can say there's a habit of having betel leaves. So one of my patients is on. I am continuously increasing his warfarin doses and his INR. Every time his INR came out to be as subtherapeutic, and we have increased doses up to 12.5 mg per day, but his INR is not obtaining. On multiple time investigating the patients, so we came to know that he has a habit of having betel leaf. So betel leaf, that's pan, have, do cause a decrease in INR because it's a green leaf. So it do cause a decrease in INR. So while counseling your patient, so you should have to ask about their dietary habits. You should need to know about their dietary habits, what they're taking, what they are habitual of taking. So that's something I've learned while monitoring while of INRs and while doing anticoagulation clinic here. Um, so my takeaway points will be counseling of patient, aggressive counseling of patients on warfarin therapy. You need to counsel each and every aspect of having of to be on a warfarin therapy. You need to tell them if your INR is subtherapeutic, what are the consequences. If your INR is supratherapeutic, what are the consequences. Then you need to ask them to have a periodic INR monitoring. You need to ask them to do check their INRs. The part of world in which I'm living, here is uh, um, in issue that usually people are not financially stable. So uh, so counsel them that it's for your benefit. It's for your benefit that you have to check your INR on weekly basis. And last and most importantly, it's the key is to have a balanced diet in a Ramadan. You should ask your patient to have foods that are low in vitamin K content, that will completely fulfill their nutritional requirements. So these are the keys, and with that, I'll wrap up my session. And from that this platform, I like to wish you all happy Ramadan in advance, and may Allah Subhanahu wa Taala accept your prayers in this month. Thank you so much.
Thank you so much, Dr. Munazza Qureshi. And no doubt, diabetes is one of the most challenging conditions to manage during Ramadan, and the patients with diabetes require close monitoring. Fasting with medical advice and fasting against medical advice is a major challenge for many physician pharmacists who treat patients with diabetes during the month of Ramadan. Our second speaker for the today's session is Dr. Ruba Dajani. Dr. Ruba is a US board certified pharmacotherapy specialist. She earned a Bachelor's of Arts degree in psychology from George Washington University and a Doctor of Pharmacy degree from Massachusetts College of Pharmacy and Health Sciences in the United States. She subsequently completed a PGY1 pharmacy practice residency at MedStar Washington Hospital in Washington, D.C., and practiced there as a clinical pharmacist for 4 years prior to joining Cleveland Clinic Abu Dhabi. At Cleveland Clinic, she established the emergency department pharmacy service, an endocrinology rounding service, and internal medicine rounding service. She is also adjunct faculty at the UAE University in Al Ain. Other area of expertise include pharmacogenomics, cardiology, infectious diseases, and burn trauma. So, Dr. Ruba, over to you for the presentation. Dr. Ruba, please unmute yourself.
Okay, here we go.
Okay, thank you.
Okay, good. Sorry about that. Okay, assalamu alaikum everyone. Thank you, Dr. Quraishi. That was a great presentation on anticoagulation and management in Ramadan. We'll now shift gears to diabetes and Ramadan. I have nothing to disclose. So our learning objectives today want to first recognize the relevance of fasting and diabetes, describe key components to consider for diabetic patients, discuss the management of medications during Ramadan, and identify barriers to guideline implementation and how to overcome them. So I'm just want to move this. Okay, sorry. Okay, much better. So it is estimated there are 1.1 to 1.5 billion Muslims worldwide, majority of whom prefer not to break fasting, even if it's at the expense of their health. Aslam et al. Reported that 45% of patients were found to change their drug dosage pattern while fasting. About 43% missed doses, 9.8% took their tablets at different times, and 4.9% took all their medications as one single daily dose after breaking fast in the evening. A survey of 325 patients in a Kuwaiti hospital found that most of them changed their drug regimens during Ramadan as well. 64% of patients changed their therapeutic scheme during the month, and about 18% took their daily medications, again, as a single daily dose, either at iftar or suhoor. Another hospital-based study in Oman of 334 patients conducted during the month of Ramadan in 2006 illustrated various characteristics of type 2 diabetic patients, including 93% fasted all of Ramadan. About 83% of type 2 diabetics in the study had poorly controlled fasting blood glucose levels. And about 49.5% of patients had unchanged insulin or oral antidiabetic doses during Ramadan. So what are key components to consider in Ramadan? The way I'm going to approach this is go through these different components. We'll start with risk quantification, blood glucose monitoring, fluids and dietary advice, exercise advice, medication adjustments, and finally, when do we have to break our fast? So risk quantification. So while fasting is considered safe for most individuals, the Holy Quran states that fasting should be avoided if it is considered to be detrimental to an individual's health. Having diabetes will put you at an increased risk for low blood sugars or hypoglycemia, high blood sugars, hyperglycemia, blood clots, and dehydration. So this is the landmark epidemiology of diabetes and Ramadan study, the EPIDAR study, where we look at the mean number of severe glycemic events per month during Ramadan compared with before Ramadan. The study found that during Ramadan, there was a 4.7 and 7.5 fold increase in the incidence of severe hypoglycemic complications in patients with type 1 and type 2 diabetes, respectively, compared with non-Ramadan periods. During the fast, patients with type 1 diabetes may fail to secrete adequate levels of glucagon in response to hypoglycemia, leading to further decrease in blood glucose levels. In addition, as a result of autonomic neuropathy, some patients with type 1 diabetes may have a defective adrenaline response and therefore an inadequate response to hypoglycemia. The incidence of severe hyperglycemia was also found to be increased during Ramadan, 3-fold and 5-fold in patients with type 1 diabetes and type 2 diabetes, respectively. In people with insulin deficiency, especially type 1 diabetics, fasting can result in excessive glycogenolysis, gluconeogenesis, and ketogenesis, and this can lead to hyperglycemia and ketoacidosis. Here, we're looking at a classification of risk by clinical conditions done by about 200 physicians, mainly in the Middle East and North Africa. They are categorized in orange, as you can see, by very high risk or high risk, and then in green is the moderate to low risk. As you can see, there is definitely a substantial difference in terms of these clinical categories, specifically severe hypoglycemia within 3 months prior to Ramadan, DKA within 3 months prior to Ramadan, all type 1 diabetic patients, a history of recurrent hypoglycemia, hypoglycemia unawareness, sustained poor glycemic control with an HbA1c greater than 10%, and pregnant women. However, if a patient wishes to fast, healthcare professionals have a duty to explore the impact of fasting for the patient in terms of risk. Deciding whether it is suitable for a patient to fast must be handled sensitively because many Muslims feel obligated to do so as an important part of their faith. Blood glucose monitoring. For the first time after being diagnosed with diabetes, or if you're considered high risk to develop hypoglycemia or low blood glucose, blood sugar, it would be good to closely monitor your blood glucose levels for the first week. And the suggested times are pre-dawn meal at suhoor, morning, midday, mid-afternoon, your pre-sunset meal at iftar, and then 2 hours after iftar, or at any point during the day if feeling unwell. If you're accustomed to fasting while being diabetic, you may check your blood glucose 1 to 2 times per day, 2 hours after iftar and before suhoor. So here is a depiction of really when you can test your blood glucose. What was interesting actually is that there was a study done in Pakistan in 2010 that involved about 1,000 patients, and it revealed that 28% thought a needle prick was not allowed during fasting. And this is false. And 55% were unaware they should break the fast if their blood glucose levels were low, anywhere between 60 to 70 milligrams per deciliter or 3.3 to 3.9 millimoles per liter, indicating here that patient education is very, very critical. Fluids and dietary advice. So here we want to divide our daily calories between suhoor and iftar, plus 1 or 2 snacks if necessary. We want to ensure that our meals are well balanced with a 45 to 50% ratio of carbohydrates, 20 to 30% protein, and less than 35% of fat, preferably from a mono and polyunsaturated source. We want to include low glycemic index, high fiber foods that release energy slowly before and after fasting, such as granary breads, beans, rice, oatmeal as well. We want to include plenty of fruits, vegetables, and salads to add to our hydration. We want to minimize foods that are high in saturated fats, such as ghee, samosas, which we all love, and pakoras. We want to avoid sugary desserts. I think this is probably our biggest challenge in Ramadan, as well as our date intake. Dates, although are highly, highly nutritious, as most of our diabetic patients know, are also very high in sugar. We want to use small amounts of oil when cooking, like olive and rapeseed oil. And we want to keep hydrated between sunset and sunrise by drinking water and other non-sugary sweetened beverages. And we definitely want to try to avoid caffeinated and sweetened drinks because those aren't hydrating, they're actually dehydrating. So here is an example of a balanced Ramadan plate for diabetics. I'll give you just a second to take a look at that. Exercise advice. So it is permissible to exercise during Ramadan, but the recommendation is to perform light to moderate exercise after iftar. It is important to note that prolonged and extended Taraweeh prayers are considered a part of the daily exercise plan and might cause low blood sugars. So this is something that you may want to perhaps check your blood glucose if you feel some sort of signs of hypoglycemia. So moving on to our medication adjustments. So dosage adjustments are going to depend on the normal timing of administration, the length of fast, and the indication of the drug. Patients taking a single dose at night are likely to have no problems. However, pharmacists who advise switching a single morning dose to a night dose should remember that some drugs show circadian variation in pharmacokinetics and pharmacodynamics. Patients on a twice-a-day or more frequent regimen are likely to need advice. Changing the timing of a twice-a-day regimen to fit the start and end of fasting can affect plasma levels, with risks to efficacy and tolerance, especially for drugs with a narrow therapeutic index. Drugs that are available in modified release forms may be an option during Ramadan, but these formulations may be more expensive. Changing a dose schedule might also mean that a medicine is taken with food, and care is needed with those that have to be taken on an empty stomach. The types of foods eaten during Ramadan are often high in fat, and this might also have an effect on absorption and bioavailability of some of the medicines. So here we'll go through our medication adjustments for our oral antidiabetic drugs. We'll go by class, and we'll start with our biguanides, which is our metformin. It is the cornerstone of therapy for type 2 diabetics. Once daily and twice daily dosing, there is no adjustment necessary. They're to be taken at iftar and or suhoor. 3-time daily dosing, our morning dose could be taken before suhoor, and the combination of the afternoon dose will be taken with the evening dose at iftar. The XR formulation here would obviously be the easiest, and here there would be no adjustment, and it would be taken with iftar. Our alpha-glucosidase inhibitors, which include our acarbose and miglitol, no dosage adjustments are necessary during Ramadan as the risk for hypoglycemia is low. Our sulfonylureas, definitely an agent class of drugs that are known to be high risk for hypoglycemia. Our once daily dosing, we would take at iftar. Our twice daily dosing, the iftar dose would remain the same, but the suhoor dose should be halved. And it's also important to note that in patients with well-controlled blood glucose, the dose actually may be reduced, and in patients with high risk of hypoglycemia as well, we may want to consider an alternative oral antidiabetic such as DPP-4 inhibitors. Insulin secretagogues, the short duration of action of these agents, these are repaglinide and nateglinide, make them appealing for use during Ramadan as they can be taken before iftar and suhoor with low risk of hypoglycemia. Moving on to our thiazolidinediones. No adjustments to thiazolidinedione medications is needed during Ramadan, and doses can be taken with iftar or suhoor. For our dipeptidyl peptidase 4 inhibitors, or our DPP-4s, no dosage adjustment is needed with these drugs either. But when used in combination therapy, the dose of the other agents may need to be modified. For example, metformin. The dose, we may need to decrease the dose. For our GLP-1 or glucagon-like peptide receptor agonist, the key here is that as long as these GLP-1 medications have been appropriately dose titrated prior to Ramadan, and this would be about 6 weeks before, no further modifications are required. And Finally, for our sodium glucose cotransporter 2 inhibitors or our SGLT2 inhibitors, no adjustments are needed for these medications during Ramadan, and doses can be taken with iftar. However, there are certain safety concerns that have been raised here with this specific class of drugs, specifically due to its mechanism of action as enhancing diuresis. So the patient population, especially that would be affected to or closely affected by dehydration, such as the elderly or patients with renal compromise, hypotensive individuals who are at high risk for dehydration, may want to consider an alternate therapy during Ramadan with these SGLT2s. So in general, for our patients with type 1 diabetes who have any of the following conditions, it is really strongly advised not to fast. Any history of recurrent hypoglycemia unawareness, poor diabetes control, and HbA1c over 10%, as mentioned earlier, brittle diabetes, non-compliance with medical treatment, or patients who are unwilling or unable to monitor and manage their blood glucose levels. Timing is everything. If you will break your fast with a snack only, so if you're going to have a soup or a yogurt date or maybe one sambusa, you want to postpone the administration of your rapid-acting insulin, such as your Lispro, your Humalog, or your Aspart Nova Rapid, in order to avoid a low blood sugar. And it would be advised to administer the rapid-acting insulin immediately before your major meal, which would include your rice or haris or pasta, whatever it is that you would be having for iftar. So dosage adjustments for on patients with insulin on an insulin pump. Here, the basal rate would be reduced by 20 to 40% in the last 3 to 4 hours of fasting. And you would then thereby increase the dose by 0 to 30% early after iftar, depending on blood glucose levels. Your bolus rate would remain the same according to your normal carbohydrate counting and insulin sensitivity principles. Here we have our dosage adjustment for patients on multiple daily injections. And the focus here is mainly, the studies were done mainly with adolescents, again, due to prior reasons I explained earlier with type 1 diabetics, with elderly particularly, who may not be able to fast. The long and intermediate acting insulin is advised to be reduced by 30 to 40% and to be taken at iftar. And the short-acting insulin, you would administer your normal dose at iftar, and you would reduce your suhoor dose by 25 to 50%. So dose adjustments for long and short-acting insulin and type 2 diabetes mellitus. So here, our long or intermediate acting basal insulin, here, whether you were taking NPH or Detamir, Lantus or Degludec once daily, the advice would be, or the recommendation would be, to reduce the dose by 15 to 30% and take that at iftar. NPH, Detamir, or Lantus twice daily dosing, you would take the usual morning dose at iftar and then reduce the evening dose by 50%, and that would be taken at suhoor. For your short-acting insulin, normal dose at iftar, here clearly you would be omitting the lunchtime dose, and then you would reduce the suhoor dose by 25 to 50%. And below is an algorithm based on blood glucose for your fasting pre-iftar, pre-suhoor blood glucose. And it shows you specifically by how much units to reduce your basal and short-acting. In our dosing adjustments for pre-mixed insulin in type 2 diabetes, for once daily dosing, you would take the normal dose at iftar. For twice daily dosing, you would take the normal dose at iftar and then reduce your suhoor dose by 25 to 50%. For 3 times daily dosing, which is not very common, but here again, you would delete or omit your afternoon dose and then adjust the iftar and suhoor doses as mentioned earlier. And here, and you would carry out the dose titrations every 3 days based on your blood glucose. And the algorithm is provided for you here. So when do I break my fast? All patients should break their fast if their blood glucose is less than 70 milligrams per deciliter or 3.9 millimoles per liter. Here you would follow your typical protocol for managing hypoglycemia, where you would recheck within an hour, and if blood glucose remains between 70 and 90, you would then retreat with either glucose tabs or a juice or a date or whatever you would take to increase your blood glucose. Any blood glucose greater than 300 milligrams per deciliter or 16.6 millimoles per liter, and any symptoms of hypoglycemia, hyperglycemia, dehydration, or if any acute illness occurs. You are, I would say you are required by medical advice to break your fast in these cases. Below is a list of symptoms for hypoglycemia and hyperglycemia that I'm sure you're all aware of. So there are barriers to guideline implementations as usual, right? Barriers may arise on an individual level within the patient or the healthcare professional, or may originate within the wider cultures of the community or healthcare system. Modifying established behavior to achieve guideline recommendations is difficult, and we're all very well aware of that. It can require changing personal beliefs and practices, as well as reshaping complex relationships within the health services and within communities. So how do we overcome these barriers? The first step to overcoming barriers to guideline implementation is to fully understand them. This enables appropriate practical responses to be configured and implemented. Many of the barriers could be overcome simply by the provision of comprehensive diabetes education, both for the patients and healthcare professionals. Combining targeted education with a series of further actions across communities and health services, such as skills training, improved communications, use of planning aids, establishment of support networks, and resource management can together help foster stronger patient-doctor relationships, as this is the basis for effective guideline implementation. Attached are my references. Ramadan Kareem, and thank you all for your time.
Thank you, Dr. Ruba. We have 2 questions, one for Dr. Ruba. What a patient with diabetes suffering from arthritis symptoms should do in Ramadan?
Sorry, can you repeat that? Suffering from what?
Arthritis.
Arthritis.
Yes.
Okay. Well, I guess it would depend on the medications they're taking. So what medications are we concerned with?
There is no further detail mentioned.
So typically with arthritis, if we're talking like anti-inflammatories, NSAIDs, or we're talking like acetaminophen, paracetamol, there are formulations that are extended release. This is really your best bet. If we're getting more technical in terms of more advanced medications such as biologics and whatnot, again, it is important to note that injections do not break fast. But most of these injections aren't daily. So I would need a little more information, but I hope that helped.
Okay, one is for Dr. Munazza. Dr. Munazza, patient is asking, can a patient take warfarin with acetaminophen if he's suffering from fever?
Ji Nabil, definitely one can take paracetamol. We advise to take paracetamol if a patient is suffering from fever. But what we do advise is to have a check on INR, because what we recommend dosing of paracetamol of 500 mg to 1 gram, and it will limit to 2 grams per day, not more than 2 grams per day. But if eventually it's needed to have more than 2 grams per day, then there should be an immediate check on INR, and warfarin dosing should be adjusted accordingly then.
Okay, thank you, Dr. Ruba, Dr. Munazza, giving back to pharmacy in Pakistan, and everyone for attending this session, and happy sharing and learning. Also, Ramadan Kareem in advance. Thank you all. Take care. Allah Hafiz.
Thank you.